either Floor, English, or French for your earpiece. If the interpretation is lost, please inform me right away. Okay, so we do have a number of wonderful witnesses present and online, and because of the volume of witnesses, I am going to be relatively precise on time, just to respect everybody's time here today. So in response to the call for public comment on the breast cancer draft recommendations from the Canadian Task Force on Preventative Care, pursuant to the Standing Order 108-2 and the motion adopted by the committee on Tuesday, June 4th, 2023, the committee will commence its study in response to the call for public comment on the breast cancer draft recommendations from the Canadian Task Force on Preventative Care. So today's meeting will take place in the form of a 2-hour panel with our witnesses so that we can maximize the time on this very important topic. I'd like now to welcome and introduce our witnesses. As individuals, we have Shira Farber by video conference. We have Dr. Ife McKirley. We have Dr. Jean Seeley, Professor of Radiology, University of Ottawa, joining us by video conference. We have Dr. Moira Rushton, medical oncologists. From the Canadian Cancer Society, we have Helena Sonia, Director of Advocacy, David Renault, Senior Manager by video conference, and Sienna Van Duzen, Advocacy Manager, Prevention and Early Detection. We also have from Cancer Care Manitoba, Dr. Pamela Hebard, Head Surgical Oncology, joining us by video conference, and Dr. Donna Turner, Chief Population Oncology, joining us by video conference as well. And lastly, from the Coalition of Responsible Healthcare Guidelines, we have Dr. Sheila Apuvu, Chair. Okay, so if you're appearing as an individual, you have 5 minutes for opening statement. If you are appearing on behalf of an organization, you have 5 minutes shared with your colleagues. At this point, I'd like to give the floor to Ms. Farber to start. You have the floor for 5 minutes.
Thank you. My name is Shira Farber. I'm here today to share my own story, but represent a sisterhood of breast cancer patients across Canada who give of their own limited time and energy to improve breast screening guidelines for all Canadians. Today is an important anniversary for me. 3 years ago to this exact date, I was at Princess Margaret Hospital in Toronto undergoing a biopsy confirming my cancer diagnosis. I can recall the visceral sensation of hearing the words breast cancer and believing in my heart of hearts that everything would be okay because I thought I had caught it early. However, diagnostic testing revealed 3 large tumors in my right breast and stage 3 breast cancer. What my surgical oncologist described as a cancer found not too late, but one that she wished she had found earlier. What I have learned and what the task force has not paid enough attention to in these guidelines is that stage does matter when it comes to quality of life and in reducing some of the side effects associated with more aggressive treatments. The chemotherapy I received was a dose-dense treatment, which made me so ill. I could not work and I spent most of my days in bed. I could not care for myself, let alone my children or mother. My mouth was full of sores, I lost all of my hair, and my joints were severely impacted. I developed iron-deficient anemia and tachycardia. I became extremely ill and was hospitalized with acute constrictive pericarditis. I almost required emergency open heart surgery. I couldn't walk short distances without being winded, and I was forced to use a wheelchair. 40 of my lymph nodes were removed, resulting in permanent lymphedema. The mobility in my arm is severely restricted. I get run down and tired easily. I do what I can with physiotherapy, but I'm living with chronic pain. The treatment protocol for a more advanced stage cancer also limited my options for reconstruction and required multiple surgeries. My body image was shattered and my mental health was severely impacted. I live with PTSD and fear of recurrence. The task force guidelines refer frequently to shared decision-making between patients and doctors. When I turned 40, I recall asking my former family doctor, who was a wonderful family doctor, if I needed to have a mammogram. I was advised that women with average risk didn't need them according to the new Canadian breast screening guidelines. I recall asking again closer to the age of 45 and receiving a similar response. I did not understand that risk factors like breast density, which can only be discovered with your initial mammogram, placed me at higher risk. I was not aware that most women with breast cancer do not have a family history. I didn't push back or self-advocate because I trusted my doctor implicitly and was fearful of the pain I had associated with mammograms erroneously. I had faced that these guidelines, if they were Canada's recommendation and those of my medical practitioner, were the gold standard and would keep me safe. Women's voices are simply not reflected sufficiently in the Canadian Task Force on Preventative Healthcare Guidelines. There is a major disconnect between what they are recommending and what actually occurs in family doctors' offices. They fail to take into account the power imbalance between doctors and patients. I speak to women with later stage diagnoses all the time. Some describe having to advocate for themselves to get a screening referral and being denied because their doctors believe they know best or are not up to date on the latest research and evidence. Some are fearful of pushing back too hard and being labeled a difficult patient and potentially losing the privilege of having a family doctor. The task force also infers one of the harms associated with screening as anxiety associated with callbacks. I would give anything in the world to experience the transient anxiety of a callback over the physical pain I have experienced and the fear I have of leaving my children without a mother or my husband without a partner. Women are resilient. We can handle anxiety with the right tools. Over the past year, I watched as the task force, while in the process of conducting an evidence review, made numerous public statements to the press on social media and lectured about what they refer to as the harms of screening. I have no faith in a process where members who claim to be objective have publicly declared and maintained their bias. When I was diagnosed with cancer, I did the same thing I did for family and friends in similar situations. I researched my doctors, I found a cancer care hospital I trusted, and I spoke to others with similar experiences. Isn't that what every Canadian woman deserves? Then why are family doctors and Canadians taking directives from non-specialists in the field of detection? Why aren't we listening to the screening experts and surgical oncologists who are at the front lines of this disease? Why aren't we learning from patients' lived experiences? Where are our voices? Canada has the ability to make this change now. We have an opportunity to give women evidence-based modern guidelines that could protect some from later stage cancers. We can't undo the past harms, but we can prevent future unnecessary suffering and deaths. Thank you.
Thank you very much for that. Next, we will pass the floor to Dr. Iffy McKeerley. Can I just kindly remind all people speaking and all witnesses, especially those online, to speak a little bit slower just so that our translators can accurately do their role. Okay, so Dr. Iffy McKeerley, you have the floor for 5 minutes.
Good morning, thank you. I'd like to thank the members of the Standing Committee for the Status of Women for this incredible opportunity to speak about the current Canadian breast screening guidelines. My name is Dr. Iffy McKeerley. I've been a general radiologist with a focus on breast imaging for over 20 years. I co-chair the patient engagement group of the Canadian Society of Breast Imaging. In my practice over the years, it has become increasingly obvious that patients who are affected by breast cancer are getting younger and younger. In addition, the increased incidence of breast cancer has also been shown in recent Canadian research. My daily practice includes diagnosing and performing biopsies on these patients, and as such, I'm often the first point of contact and the deliverer of bad news. Breast cancer in younger women tends to grow faster and is more aggressive. The task force has recently released their recommendations for breast cancer screening. It is important to acknowledge that the task force members do not specialize in the field of medicine, breast cancer screening, for which they have set the guidelines. They have mistakenly placed higher emphasis on the potential harm that early screening may cause rather than the life-saving benefits. Breast cancer is a disease that has a far-reaching impact. The brutal harm of a late-stage diagnosis is significantly more severe than the potential harm of undergoing additional imaging. The outdated study from the 1980s, which the task force continues to use to make their guidelines, was comprised of a population of 98% white women. 40 years later, however, Canada is a much more racially diverse country. Over 9.5 million Canadians were identified as a member of a visible minority group in the 2021 Canadian census, making up 26.5% of the total population. In the US, it was noted that in Black, Hispanic, and Asian women, breast cancer peaks at an earlier age of 40 when compared to white women. Recent Canadian analysis shows that Caucasian women are the only group whose peak incidence is greater than 50. The task force was aware of this recent, yet to be published paper from Statistics Canada, but did not lower the screening age. In the recently released guidelines, the task force notes that the lifetime risk of breast cancer in these populations is lower than the risk in white populations. They go on further to note that non-white populations in the 40 to 49 age group are diagnosed more with breast cancer, have a higher proportion of aggressive subtypes of cancer, are less likely to have hormonally sensitive cancers, and less likely to have stage 1. Black women have an even more sobering outlook with a 42% higher mortality than white women, more aggressive cancers, and stage for stage, worse outcomes. For the 40 to 49 age group, the task force notes, and I quote, there are data showing variability in incidence, mortality subtype, and stage at diagnosis. Example, higher mortality in Black women. Despite listing all the disadvantages facing racialized women, they put a strong emphasis on informed patient choice, which would require an educated discussion with a family physician. The task force promotes a one-size-fits-all approach, which counters the observed variability in values and preferences. If a woman chooses to be screened, they still recommend screening every 2 to 3 years. When the U.S. guidelines were announced, the U.S. task force stated that new and more inclusive science had led it to call for screening at 40. In Canada, where's the use of new and inclusive science? With knowledge comes responsibility, and so knowing the above, acknowledging higher mortality in Black women in the 40 to 49 age group, and not acting on it is simply unethical and discriminatory. The task force also discriminated against women with dense breasts by not recommending supplemental screening. Breast density is highest in Asian, Black, and Hispanic women. It's 2024. We must include the 40 to 49 age group in the screening population, particularly given the incidence in racialized women and higher mortality in Black women, as well as the high risk to women with dense breasts. Lives depend on it. In the absence of proper governance and an accountability structure for the task force, and indeed for any organization, there's chaos. Women in their 40s are not acceptable losses. Thank you.
Thank you, Dr. McKirley. Next, we have Dr. Jean Seeley. You have the floor for 5 minutes. Go ahead.
Members of the Standing Committee on the Status of Women, thank you for the opportunity to comment on the draft Task Force Breast Cancer Screening Guidelines. As a breast imaging specialist, I diagnose women along their entire cancer journey. I detect breast cancer from screening, or I diagnose it after a woman presents with a palpable lump. I perform breast biopsies, and I localize breast cancers for the surgeons. I interpret the imaging of women diagnosed with late-stage or recurrent breast cancer. I speak to women at all stages of breast cancer, and screen-detected cancers found before symptoms occur as a very different diagnosis than one found because of symptoms at stage 2, 3, or already metastatic at stage 4. The task force falsely states that an additional imaging test is a harm comparable to a delayed diagnosis of a late-stage breast cancer. My patients attest that the severity of the harm of a delayed diagnosis vastly exceeds any stress associated with an additional imaging test. The recent draft guidelines released by the Task Force for Breast Cancer Screening have sparked significant concern within the medical community. And as an expert included on the evidence review panel, I found their recommendations profoundly disappointing. These guidelines ignore robust recent evidence that supports the initiation of screening at age 40, a standard now adopted by the U.S. Task Force and by numerous other countries worldwide. The task force recommendations are anchored in studies that date back 40 to 60 years, using obsolete technologies such as film screen mammography. This reliance on outdated data overlooks monumental advances in breast cancer treatment, including hormone receptor-positive treatments, less invasive surgical options like lumpectomy, sentinel lymph node biopsy, and all the modern immunologic and chemotherapeutic agents that have completely revolutionized breast cancer management. The task force approach diminishes the importance of recent observational trials that involve millions of women comparing screening to no screening using updated diagnosis and treatment. This includes a large Canadian study of over 2.7 million women screened over 20 years, showing a 44% reduction in breast cancer mortality in women who began screening in their 40s. And similar studies in Sweden show an even greater benefit with reduction in mortality of 50 to 60%. Breast cancer is a devastating diagnosis, but the harms are mostly preventable when it is detected early. The survival rates are starkly different across the stages. It's nearly 100% 5-year survival for stage 1 detected by screening, compared to only 22% 5-year survival for stage 4 when the disease has spread and become incurable. And further, the treatments are much less intensive and less costly when treated early. Stage 1 costs an average of 36,000 Canadian dollars to treat, as compared to stage 4, which costs can exceed $500,000 per patient diagnosed. And these statistics underscore the critical importance of early detection, which the task force draft guidelines failed to adequately prioritize. The task force disregarded data that showed that women of race and ethnicity other than white are more likely to be diagnosed with breast cancer in their 40s. This one-size-fits-all approach to recommending screening only starting at age 50 discriminates against these women and contributes to their twice higher rates of advanced breast cancers due to delays in diagnosis and lack of access to screening mammography programs. The task force also acknowledged that women with dense breasts were twice as likely to develop breast cancer as women with non-dense breasts, but it failed to recognize the reduced sensitivity of mammography in these women, which drops from as high as 90% in women with non-dense breast to low of 60% in those with the densest breast. The task force ignored very high-quality randomized trials that showed that adding screening with MRI reduced interval cancers, those are found by symptoms after a normal mammogram, by 80% with MRI and by 50% in those screened with supplemental breast ultrasound. These interval cancers have been shown in evidence-based medicine to be acceptable surrogates for breast cancer mortality, which may take 10 to 20 years or more to demonstrate. They failed to acknowledge the importance of supplemental screening in these women and, again, are not following international standards. We must demand that our health policies be reflective of the latest scientific evidence and best practices in medicine. As a medical community, we owe it to every woman in Canada to advocate for guidelines that are not only scientifically sound, but also reflective of modern medical technology and treatment advances. Let us stand together to call for an immediate review and revision of the task force guidelines to truly reflect what is best for women's health today. Thank you very much.
Thank you, Dr. Seeley. Dr. Rushton, you have the floor for 5 minutes.
Thank you. Honorable members, thank you for your invitation to testify today on breast cancer screening. As a medical oncologist, as well as a 41-year-old woman, both concerned for the well-being of my patients and the health of my generation, I was deeply disappointed with the draft report from the Canadian Task Force for Preventive Healthcare last month. The report significantly overstates the harms of screening while ignoring the benefits of early detection. What has been missing from the ongoing public discourse is the benefits of early detection of breast cancer from a treatment perspective. We hear frequently about the harms of screening, but there's been little discussion about the differences in treating a cancer that is clinically evident versus screen detected. Treatment of breast cancer is complicated and it is expensive. Beyond surgery and radiation, I offer patients medical treatments to reduce their risk of recurrence or dying of cancer. While the task force mentioned chemotherapy and no chemotherapy, our treatments today go far beyond that, including things like immunotherapy, targeted therapies, antibody-drug conjugates, cell cycle blockers, and up to 10 years of hormone-blocking therapy for patients with stage 3 hormone-sensitive breast cancer. Catching a breast cancer at an early age where it becomes clinically detectable reduces the need for extensive medical treatment and lowers the risk for distant recurrence and death. A larger tumor with lymph node involvement, which has become clinically evident to a patient, means higher risk disease and therefore more treatments to achieve the similar outcomes, leading to higher costs for both individuals and our society. Individual costs include time out of work, hair loss, cognitive dysfunction, chronic fatigue, sexual dysfunction, infertility, premature menopause, nerve damage, cardiac complications, mental health issues, not to mention the constant fear of recurrence. The financial toxicity of breast cancer treatment is real and is carried by all of us in our publicly funded healthcare system. As was just mentioned, we know that the costs significantly increase by stage, with a screen-detected stage 0 cancer costing only about $14,000, whereas a stage 3 cancer management in Ontario today, based on our treatments we use, publicly funded, costs nearly $400,000. This year, we took those numbers and put it into cost-effective analysis using the same OncoSim modeling that CPAC has endorsed, and found that not only is this cost-effective, but it's cost-saving, because the treatment of breast cancer at stage 4 is so very expensive. Screening typically diagnoses breast cancers at an early stage. Only 35.7% of women aged 40 to 49 in Ontario are diagnosed with stage 1 disease in the absence of an organized screening program, whereas for those that participate in the Ontario Breast Screening Program between 50 and 74, nearly 87% will be diagnosed with stage 1 or stage 0 cancer. The communication tool provided by the task force meant to inform discussions between patients and their primary care providers about the risks and benefits of screening at an earlier age makes no mention of the downstaging that's achieved by early detection with a screening program. The updated guidelines raise many questions. There are major discrepancies between the Canadian and U.S. task forces in terms of the benefits estimated for population-based screening. The U.S. task force predicts more deaths averted and life years saved than the Canadian task force by reducing the age of screening to 40. But even with the conservative Canadian estimate, lowering the age of screening to 40 from 50 would prevent an additional 2,600 deaths over the 10 years of screening in the demographic of women aged 40 to 49. The task force has opined that this benefit does not justify the harms of additional testing and a few overdiagnosed cases. On this point, I disagree, as does the literature, where we know that women will accept up to 6 overdiagnosed cases to save 1 life. The task force has also ignored the long-term benefits of early detection by focusing only on a 10-year time frame in terms of both the report and the discussion tools to evaluate the benefits of screening. The reality is, for the most common type of breast cancer, which is hormone sensitive, even if you have a stage 2 or stage 3 breast cancer that may come back some way, probably even if it does recur within that 10-year time frame, by 10 years you're still going to be alive. You'll just have stage 4 disease and living through chronic treatments. As my patients will tell you, living with cancer is not the same thing as surviving it, but the tools being provided to our family physicians make no differentiation of the 2 points. Until we figure out a way to prevent breast cancers from developing, the only way to reduce morbidity and mortality, as well as the cost to our healthcare system, is with early detection. The task force has significantly minimized the risks of the benefits of early detection and has not provided transparent modeling data about downstaging that can be achieved with organized screening program. Without this crucial part of the conversation, we are only informing women with half of the story. I hope my testimony today will start a broader conversation about the harms of breast cancer treatment and the risks of delayed diagnosis. Thank you.
Thank you so much, Dr. Rushton. At this point, I would like to give the floor to the Canadian Cancer Society. Your organization now has the floor for 5 minutes.
Gestionnaire en prévention et détection.
We are here today I'm with David Reynaud, Senior Manager for Quebec. We are part of the team of the Canadian Cancer Society for Canadians who are concerned with the society. We are working to save lives, and we want to provide cancer screening advice. The society is the main entity for Canada. We see 2 people out of 5 will receive a diagnostic of cancer over the course of their lives, and 1 in 4 will die of the disease. In Canada, we find that 1 woman out of 8 receives a breast cancer diagnosis during the course of her life. Breast cancer is the most commonly one diagnosed in Canada, and even if there are fewer cases among women under the age of 50, it remains to be the primary cause of death through cancer for women from the ages of 30 to 49. Even if data shows that breast cancer for women in their 40s has increased over the last 35 years, the global cases around the world and in Canada have gone down because of treatments and care that will continue to improve. And yet, international data indicates that a greater number of Black women, Spanish and Asian women who are affected with breast cancer are diagnosed before the age of 50. And moreover, they are more often diagnosed with an illness that is at a later stage than other women. And that is why starting screening at the age of 50 is an opportunity missed to have early diagnosis. There are advantages to regular screening that are systematic for breast cancer from the age of 40. This is the time to screen in order to find this cancer early when the treatments have a better chance of succeeding. We'll continue to hear from people who have been affected by breast cancer that are not represented with the current guidelines because they don't reflect their lived experience. Moreover, a national survey showed that most women supported early screening from the age of 40. Our organization supports systematic screening for women who are low risk and between the ages of 40 and 50. We also need to ensure that there are clear directives that for people who present a higher risk of developing breast cancer, such as women who have certain genetic mutations, who have a family history, or dense breast.
I don't see
Est-ce que vous
it on
m'entendez?
screen. Oh,
And now can you hear me? Okay. Sorry. Thank you, Sienna, and thank you to the committees. A growing number of provinces in Canada currently have begun to expand access to breast screening from the age of 40. And while the provinces and territories are looking at the new national guidelines, the Canada Cancer Society is asking people to include the 40 to 50-year age bracket for breast screening in their programs. This change also reflects the new data that have been published since the last update of the guidelines in 2018 and those that were presented a few weeks ago. The evidence on breast cancer in Canada will soon be updated by another entity, which was a survey that started before the pandemic. And we have not reached the level of 70% of respondents. We have to take into account the populations that are poorly served. And the Society, moreover, recommends that the Canadian government invest more in this cancer. And we also have to close the gaps in the data so that we have a better understanding of breast cancer in Canada. And the Pan-Canadian Strategy and the Health Charter shows interesting opportunities to improve the data in the country. Governments must invest more in prevention and early screening treatments to reduce the impacts with the workers' shortage. So this needs new investments in human resources and technologies and digital capacity to meet the actual and future need of Canadians. And finally, I'd like to thank you for having taken the time to listen to our recommendations. We are looking forward to working together to support people affected by cancer. It takes a society to help people affected by cancer. Thank you.
excellent. Thank you, Mr. Renaud. At this point, I would like to give the floor to Cancer Care Manitoba. Your organization has 5 minutes.
Thank you very much, Chair, and the committee for the opportunity to speak about the draft guidelines prepared by the Canadian Task Force on Preventive Healthcare, also known as the Task Force on Breast Cancer Screening. This is an important topic, and all of us here today want to reduce the impact of breast cancer on Canadian women. It's important to remember we are united in this goal, even if opinions and perspectives differ. I am Dr. Donna Turner, an epidemiologist and the Chief of Population Oncology at Cancer Care Manitoba, and joining me today is Dr. Pamela Hebard, who is a cancer surgeon and the head of surgical oncology for Cancer Care Manitoba. Breast cancer is a complex subject, and considering breast cancer screening, we find there's often confusion about what is screening and what is not. Screening is a test offered to all women who do not have symptoms and who have an average risk of breast cancer. Women who find a lump in their breast or who are experiencing symptoms that are not normal for them need a diagnostic workup. Women who are at higher than average risk due to family history or genetic predisposition are often best served by tailored or individualized screening. Regardless, our message to all women is if you experience something that is not right for you, please see your healthcare provider right away. In our province, Cancer Care Manitoba works to deliver evidence-based programs while supporting Manitobans throughout their cancer journey. For example, as a result of the evidence coming forward related to screening, we are promoting screening where the evidence is strongest, including women 50 to 74. I note that like other Canadian jurisdictions, we have not achieved the 70% target rate among women who are most likely to benefit from screening. That is, those in these age groups. Second, we work with communities and Manitobans who are at risk of being underserved by our healthcare system, including those who are racialized, gender diverse, and or residents of geographically remote communities to reduce inequities in breast cancer screening access and ensure improved health outcomes. And third, we are acting with our healthcare partners to provide avenues to best support all women to make informed decisions about their health. Based on recent evidence, this includes women aged 40 to 49 who may want to explore their options for mammography by further understanding the benefits as well as the harms. And at this time, I'll turn it over to my colleague, Dr. Hubbard.
Thank you, Chair, for the opportunity to be here today. As Dr. Turner mentioned, I am the head of surgical oncology, and my clinical practice is dedicated to the treatment of breast cancer and gastrointestinal cancers. Particularly with breast cancer, the number of scientific studies are immense and varied. It is important that we don't make health policy decisions based on personal bias or even on a well-meaning desire to make a difference. You need experts who are impartial. They need to not have skin in the game. The statistics that go into these recommendations are complex, and you need experts to interpret the data correctly. There is misconception that mammography will prevent cancer or significantly de-escalate the treatment required. This is actually the exception rather than rule. Breast cancer is not a single disease. We tailor breast cancer treatments based on protein profiles, which is the largest determinant of their treatment. Based on cancer subtype, there are some 5 millimeter cancers that will get chemo, and there are some 5 centimeter cancers that will not. In the modern era of breast screening, this largely impacts how many women are diagnosed with stage 1 versus stage 2 cancers, with stage 3 and 4 cancers largely unaffected by screening programs. The treatment of stage 1 and 2 breast cancer is largely the same. I believe the harms of screening are real. We know younger women are more likely to have an abnormal screen, which results in multiple follow-up tests and biopsies. Women commonly report this process as highly distressing. In some women, it is so distressing that they never go for screening again and miss out on future benefits. But on a healthcare system level, an increase in mammograms is a large financial and human resources problem. But the outflow of follow-up testing and biopsies is the greater problem and risks creating new and very significant delays in the diagnosis and treatment of those who actually have cancer. So what would be the most impactful to the breast cancer landscape in Canada? We need to increase screening in our current age groups, include women and remote who have social disadvantages and belong to minority groups. In my practice, I see women who die of colorectal cancer at a young age, people with cervical cancer and many other diseases. And I personally see the lack of access to primary care driving more deaths in young women and young men due to this healthcare crisis. We also have too few studies on breast cancer prevention, and there really needs to be a renewed focus on this. In conclusion, I thank the committee and all the people who are here today who have a passion to improve the future of this disease, even if we see a different way forward. My final comment is that I'm a 47-year-old mother, breast cancer surgeon, and healthcare leader, and I have not personally had a mammogram because I do actually believe in the work of the Canadian Task Force. Thank you very much.
Thank you, Dr. Hubbard. Lastly, we have Dr. Sheila Apuvu. You now have the floor for 5 minutes.
Thank you very much. Honorable members of the Standing Committee for the Status of Women, thank you for convening this important study with such urgency. I spoke yesterday at HESA, so any resemblance between today's statement and my statement from yesterday is purely coincidental. I'm Dr. Sheila Apavu. I'm a general radiologist with an interest in breast imaging. I founded and co-chair, along with Dr. McCurley, the Canadian Society of Breast Imaging Patient Engagement Working Group. And I also founded and chair the Coalition for Responsible Healthcare Guidelines. I speak today about my serious concerns about the recent draft guideline issued by the Canadian Task Force on Preventive Healthcare regarding breast cancer screening, recommending against screening women 40 to 49. This guideline stands in stark contrast to those provided by the U.S. Task Force, the Canadian Cancer Society, and the majority of Canadian provinces, all of which have recognized the need to lower the screening age to 40. The Nurse Practitioners Association of Canada has also recently withdrawn their endorsement of the similar 2018 Task Force guideline. The decision to not screen women 40 to 49 is biased. The May 30th news that the task force had again refused to recommend screening for 40 to 49 was not a surprise to those of us following along with the guideline development process. The result was predetermined. The task force leadership indicated in the media in early May 2023, immediately following the release of the U.S. task force guideline draft, that there was no need to change the Canadian guidelines. This was before the evidence review began. And lo and behold, this prophecy was fulfilled almost exactly a year later. How does the task force come to such different conclusions than the rest of the modern world? Without the context provided by the fulsome guidance of experienced content experts, they amplify harms such as overdiagnosis, benign biopsies, and callbacks for additional imaging, and they minimize the benefits of early detection. In their calculations, they do not include important morbidity benefits of screening, such as decreased rates of mastectomy, chemotherapy, or lymphedema, a permanent, disabling, and disfiguring form of arm swelling, which is caused by aggressive lymph node surgery needed for later stage cancers. The task force's focus on the harms of screening, particularly anxiety of recall, is paternalistic. The paternalism of making decisions for women because of their concern about the possible anxiety reaction to a recall is disturbing. It's tantamount to saying, don't worry your pretty little head about breast cancer. If instituted, the consequences of these new task force guidelines will be dire. Many young women will potentially pay with their lives. Most provinces and territories have recognized this and have allowed self-referral for women aged 40 to 49. However, the recommendation of a primary care provider is still the strongest predictor of whether a woman will actually go for screening. As long as doctors are being given the task force message that women in their 40s don't need screening, many of those women won't get access. By continuing to make the same breast cancer screening recommendation that the task force has made since 2011, Canada's national guideline is falling farther and farther behind the provinces, other countries, and expert recommendations. Unfortunately, these guideline problems are not isolated to breast screening and are a pattern seen in multiple other guidelines, including those that directly affect women's health. Please bear with me as I veer slightly off the topic of breast cancer, as this is important for context. The task force's pregnancy and postpartum depression, lung cancer, and cervical cancer screening guidelines are similarly dismal. All these affect women. The cervical cancer guideline has not yet been updated since 2013, despite multiple landmark studies that should have prompted a revision. It does not recommend HPV screening, although this was recommended nationally and instituted in countries such as the UK, Australia, Norway, and the Netherlands dating back to 2017. While Australia is on its way to being the first country to eliminate cervical cancer through vaccination and HPV screening, women in Canada have been getting invasive cervical cancer avoidably for the greater part of a decade because of this weak task force leadership. We must not allow these guidelines to stand as they are. We must have a breast screening guideline that is informed by the latest evidence and not by paternalism, one that truly serves the best interests of Canadians. And with respect, looking at its record, we must dismantle and rebuild the Canadian Task Force on Preventive Healthcare to safeguard Canadians in the future. Thank you for your attention to this critical issue.
Thank you all very much for your opening remarks. At this point, we will move on to our rounds of questioning from members. I'd like to begin with Anna with the Conservative Party for 6 minutes.
Thank you, Madam Chair, and thank you to all the witnesses for being here. This is an important topic, especially for women. And I have a question for Dr. Sheila Apfel? Oh, I'm sorry if I mispronounced that. Can you explain to me, if someone has been adopted and they have no family history, what is the best test in ensuring the prevention of breast cancer?
So screening is considered secondary prevention, as opposed to preventing the cancer. It prevents late-stage cancer diagnosis. In general, we treat people who have no available family history, so whether they're adopted or estranged from their family, we treat them as average risk. And again, our recommendation is to start at 40 and screen annually until they are within 10 years of life expectancy.
And my other question is, if there is a family history, and this has happened to someone I know, if there's a family history of breast cancer is detected in one of the breasts. So in Ontario, they'll remove that breast, but not the other one, because it's considered cosmetic. However, with this particular individual, 2 years after the breast was removed, she received a diagnosis in the second breast of stage 3 breast cancer. Why wouldn't they have removed both?
I can't speak to Ontario, and I'm not a breast surgeon or treatment. I'm more involved with diagnosis. But perhaps I could defer to one of my colleagues who is more of an expert in that field, Dr. Rushton.
Sure. So I'm not a surgeon. But I do see a lot of patients with early-stage breast cancer. The current guidelines for surveillance after a breast cancer diagnosis is to have annual breast imaging of both breasts. Having a singular breast cancer diagnosis does increase your risk of having contralateral breast cancer. So for our breast cancer survivors, our recommendation is to have annual screening mammography for essentially the rest of their lives. Typically, for a patient that's undergone treatment, they would have their first screening mammography, at least here in Ottawa. Our standard would be to do it 6 months after the completion of radiotherapy as their baseline. So it's hard to, I agree with Dr. Apabu that it's very difficult to comment on an individual case. And I think some of our guidelines have evolved over the years, and now we're doing a lot more MRIs for patients at time of diagnosis, especially if they have risk factors like Dust's breast, to ensure that there's no small contralateral lesions which are being missed. But it is currently not the standard of care to automatically do a prophylactic contralateral mastectomy, because it has not been demonstrated to improve survival. The focus rather is annual screening in all breast cancer survivors, which is also a problem in our breast screening programs, because in most provinces, breast cancer survivors are excluded from screening, meaning they have to go back to their primary care provider year after year to get that screening mammogram.
So my question is, in this particular situation, the mother had breast cancer, 2 of the 3 siblings have breast cancers, and the doctors of the siblings have recommended that the female grandchildren, because it is a pattern, because the great-grandmother also had breast cancer, were refused by their family physician not to have the screening because they were under the age of 40. However, because they've had multiple history going back, 100 years, why would we not go ahead and do the mammogram?
So family doctors in Canada go through 4 years of medical school and 2 years of residency training for their specialty. They have extremely limited exposure to any sort of education around oncology, and breast cancer is no exception. At the University of Ottawa, they get about 1 week of oncology lectures in their time during medical school, and there is no mandatory training in oncology. So it's basically delved. So this is the real biggest issue with these task force, is that the task force guidelines are about as much as a family doctor has time to understand and process. So if a big national organization recommends against routine screening, then they are not going to do routine screening, because they do not have the time, and nobody has taken the time to educate them or include this in their medical education over the years. That family that you speak of should have, and if they have not, be referred to medical genetics for genetic screening. Those members of that family should be in a high-risk screening program.
So would you agree that we have to put the patient care back into the patient? Because I agree with you. Doctors, we have a limited let's face it, we're shortage. There's a shortage of family doctors, a shortage of experience. But do you agree that lives are more important than skipping a step?
Absolutely. I do think that like this discussion around screening and health screening is an opportunity for us in Canada to think about more meaningful healthcare reform, where we can think of what are the evidence-based ways that we can help save lives, and how do we skip that step of outside of a primary care provider, because our family physicians are burning out. They do not have the capacity for us to be putting more on their plates by saying, now please have detailed risk-benefit ratios. As a government, our government organizations, I'd really like to see the government, public health, provincial health providers providing screening programs that our patients can self-refer to, much like is about to start in Ontario in the fall, so that they can make that decision, and then they can follow up with their family discussion provider to review the results. Trying to make family doctors continually be the gatekeeper to all medical care in Canada fails so many, because like even in Ottawa, about 30% of people don't have a family doctor.
Thank you very much. Thank you very much. At this point, we'll move on to Sonia. You have 6 minutes with the Liberal Party. Thank you.
Thank you, Chair. Thank you, all the witnesses being with us. My first question is to representative from Canadian Cancer Society, and then all the witnesses who want to contribute on that. I would like to know about the differences across provinces and territories in their approach to outreach to women testing and treatment for the breast cancer.
Yeah, so we know that the recommendations are as such, they're guidelines, and that provinces have the ability to make informed decisions for their populations, and they are doing so across Canada. In the last few months, we've seen various provinces make the decision to expand access, whether self-referral or systematic screening. It is important to note that there is a difference there, and that self-referral does still require women to know that they have access, that they have a right to it, that they go and get it, and a certain amount of education and resilience in pursuing that, as opposed to a systematic approach where the invitation comes to you and it's a lot more streamlined and clear. And so those are, some differences as far as how we carry out access to breast cancer screening, but both are certainly steps in the right direction. I'm not sure if there was a second part to your question as far as differences.
Thank you. Anyone else would like to contribute in that? Okay. If not,
yes.
Go ahead.
Oh, sorry. I thought you wanted the answer.
Yes.
I can tell you that the Canadian practice has been a patchwork of guidelines. Some provinces have been screening women in their 40s by allowing self-referral since the program started in British Columbia, Nova Scotia, Prince Edward Island. Others have come on board, and currently, as of this date today, all the provinces and territories, except Nunavut, which does not have a screening program, and Quebec, which is looking at the evidence for screening women in their 40s, and Manitoba is the only one that has not adopted this policy for self-referral for women in their 40s. Alberta starts at 45. The other provinces all start at age 40. So we have had the opportunity to study this differential, and what we've shown in a large study done with Statistics Canada, that the women who have been diagnosed with screening in the 40s in these provinces that have been screening have a significantly higher rate of early stage breast cancer, and the provinces that do not include those women in their 40s have significantly higher rates of those more advanced cancers at stage 2, stage 3, and stage 4. There's also differential in approach to density. So this is the opportunity that we have for the guidelines to make a more standardized approach, and one of the reasons why we're so disappointed with the draft guideline. Thank you.
Follow up.
Dr. Sonia, Dr. Turner, I believe, wants to contribute to that as well.
Yes. Thank you, Chair. I just wanted to note that in some provinces, for example, in Manitoba, the breast screening programs work very hard to connect with communities of various racialized populations and in Indigenous populations in particular in a province like Manitoba. I think it's really important to note that one of the things that we have not done well in Canada is to capture information on race and ethnicity, or in fact, in terms of gender identity. this is an area where we see that there is a great possibility for advancement. And in Manitoba, our breast cancer screening program is asking women to self-identify as terms of their race, ethnicity, and indigeneity, following a practice that has been developed in Manitoba with communities and in partnership with communities and healthcare leadership. And it's really an important step forward in us getting more information on what it is that we can do for women who are in potentially equity denied populations.
Thank you, Dr. Turner. You raised a very good point for the data collection for racialized on Indigenous population. Do all provinces collect the data, and what could you tell us about data collection specifically for racialized women? Cancer Society can answer, or anybody.
Maybe I can answer that because I was involved in a large study with Statistics Canada. Unfortunately, the data for race and ethnicity is not collected and not correlated with the method of detection of breast cancer. So we had to do a very circuitous registry adjustment and correlate it with the census data to be able to provide that race and ethnicity data. This is really a significant gap that we need to be able to collect these kind of data to be able to show the impact of screening in these women of different race and ethnicity. Our data does show that there is a very significant harm being done to the women of other races and ethnicities other than white, and that includes Indigenous women and women of all ethnicities in Canada with that higher rate of advanced stage breast cancer. So this is a call for increasing the data collection in different provinces and territories to be able to capture this more readily and to demonstrate the impact of screening at diagnosis.
Sonia, I do see that there are several others that want to contribute to this conversation, but your time is up. So perhaps those that do have your hands up, if you can find room to provide your answer in some of the following questions. Next, I'd like to invite Adrienne Larouche. Vous avez 6 minutes avec le bloc.
You have 6 minutes. Thank you very much, Madam Chair. Thank you to all of the witnesses for being here with us today. Remembering or recalling that this is a cancer that is devastating to women and to entire families. We almost all know women who have died or are still living with the consequences of breast cancer, and that's my case, in fact, Madam Chair. And I thank you to all the witnesses for collaborating in this study, and in memory of all those who died, and in solidarity with all those who hope to live. To our witnesses, I'll begin with the Canadian Cancer Society. So, Ms. Van Dusen and Mr. Reynaud. What I hear today is that there are more and more studies that demonstrate the importance of preventive care. So I would like to hear you speak, because concerning the guidelines, that's the intention of the guidelines, is for people 40, perhaps Quebec doesn't have those, although we're working on something in the province. And there are international examples. Nobody wants to move backwards on these guidelines for 40 years olds.
Evidence, reports, data, methodologies across various areas that are demonstrating, that are demonstrating the advantages, both in terms of the lived experiences of these people diagnosed with cancer, but also the advantages of our system, catching cancer early when it's most treatable. It's also less expensive. I think that when we look to the United States and their guidelines having changed most recently is a good indicator. We have race-based data internationally that we have not previously seen or had access to, and we know we have a very diverse population in Canada that we need to be meeting the needs of. I'll also just mention that there are women in that age that currently have access, 50 to 74, who are not being screened. And it's really important that as we consider expanding access, that we're not leaving these people further behind, and that we are supporting this expanded access, which women should have, with resources, whether that's health, human resources, technological, financial, so that we're delivering this in the way that it is intended.
Monsieur Reynaud.
Mr. Reynaud, would you like to add something? Yes, can you hear me? Okay, I think my mic's working now. Clearly, prevention, because we're talking about early screening and prevention. We could also say, as was mentioned in our statement, that upstream we try to promote healthy habits, but clearly early screening is key in order to increase survival rates. Because even with survival, there are the impacts of treatment and secondary effects, as we've heard with some of the stories shared today. But with all of this, having better screening allows us, in fact, to limit the burden of treatments and secondary effects on patients of those. So also we save money for the healthcare system, because there might be lighter treatments that might be offered in the case. So that is just to add to what my colleague said. You said it well. We started with gripping testimony by Ms. Farber. Mr. Reynaud and Ms. Van Dusen, I'd like to carry on. We're talking about guidelines, but in the end, we know that it's all well and good to have guidelines for people 40 years old, but if the federal government doesn't do its part to ensure that there are the proper investments, and I'm talking about transfers here, if they don't invest enough in the healthcare system, as has been the case for years, they've let systems break down in Quebec and in the other provinces. They haven't met the expectations of the provinces of Quebec and the other ones. They say good things, but then the provinces, which manage their own systems, they're the masters of their own systems, must have the resources and the human resources. So what is the importance of reinvesting in health and not have healthcare be the victim of austerity, and that we have the financial means to really invest and follow up with appropriate treatments?
I don't want attempt to answer that. Recent studies done by, I think, Dr. Seeley and colleagues have shown that based on screening annually from 40 to 74, based on modeling and modern treatment costs, which are very, very expensive, Canada would save about $460 million per year in treatment costs. And so I think investing in screening will pay back in spades for the government. And I think they need to take the plunge, make the investment up front, and I think they will reap the rewards in the next few years after that.
Thank you.
Merci pour les dernières secondes qui me restent.
Thank you very much.
3 seconds, so.
Alors, on voit que non seulement on aurait
So we can see that we need more money, but also prevention would allow us to invest more for the victims. Thank you.
Next, we have Leah. You have 6 minutes as well. Thank you, with the NDP.
Thank you so much. Want to thank all the witnesses. The testimony is just magnificent. So if we can keep our responses brief, I have an agenda. So one of the comments that was really shocking to me is that, you know, people making decisions can't have skin in the game. I actually disagree. My first question was for Madame Farber. I'm wondering if you could provide a key recommendation to our committee to improve the healthcare system based on your experience. If you had one key recommendation, what would it be?
Thank you. So as it pertains to screening, because I know that's why we're here today, or these guidelines as it pertains today, I firmly believe that Canadian women should be allowed to self-refer and be included in a screening program starting at the age of 40. And I believe that women over the age of 74 who want to participate and continue to should be able to do so. There are a lot of women in their later 70s who are in great health that would like to have the right to detect their breast cancer early too. I believe that women who have breast density should know that. I think that's a major risk factor. I didn't know that I had dense breasts until my pathology results came back. How would I ever know that that was a risk for me because I had never had a mammogram before my cancer diagnosis? So in my opinion, that's what will empower women and allow them to have these discussions with their family doctors. Those of us that are lucky enough to have family doctors, as we know, there are a lot of Canadians without family doctors right now.
Thank you. Thank you so much. My next question is for Dr. McKirley. McKirley, is that right? McCurley, sorry. Shocking, but not shocking. I'm wondering, are you aware of the makeup of the task force right now? Yes or no?
Yes.
Yes. What is the number of folks on the task force that are from Black, Indigenous, and people of color backgrounds?
I am not sure actually what their ethnicity is, but I think it's very few of them.
Okay, how about women?
I'd have to check.
You would have to check. Yeah. Okay. Okay, I ask that because I think inclusion is intentional, and sometimes we don't look at specific factors if certain people are excluded from tables, so I am concerned about it. Dr. Apaveau, you spoke about paternalism, and don't worry your little pretty head about it. Can you expand on that, and what is a key recommendation you would make to address that level of paternalism that seems to be costing the lives of women and gender diverse people?
Thank you for asking that question. I think there's paternalism at several levels. One of the most obvious is the idea that recalls are a harm that should be weighed against the possibility of an avoidable late-stage diagnosis, which may mean harsher treatment and potential death. A recall is where somebody gets pulled over after their mammogram to go back for extra testing. I liken it to going through security at the airport, and they put your bag through there. You carry on through the X-ray, and then every once in a while they'll see something on your X-ray in your bag, ask you to come over, check your bag, and then most of the time you're not carrying anything dangerous and you can just go on your way. And that's very much similar to what the process is with mammography. A recall is not a harm. It's unpleasant. I do not diminish the level of anxiety and shock that there is in finding out you have to go back for another look, but it's transient. And the reason people are worried is they don't want to die of cancer. And that's what this is all for. We are trying to avoid people from dying of cancer. So they get worried when we call them back, but that's part of the process. And it's a lot of hard work not to die of cancer.
So what would your key recommendation be?
My key recommendation would be to acknowledge the anxiety, but not put it into an equation where you weigh that against the potential benefits of not having late-stage treatment or potential death. It is something to acknowledge, warn people about, but it has no business in an equation.
Okay, thank you. You have something to add?
Yeah, I was thinking about that question in terms of knowing what the specialties of the people that comprise the task force are, particularly with your comment about having skin in the game and the bias for breast experts. I've always thought about that and wondered, what is the bias? We, as radiologists in probably most institutions out there, we're known as people that are busy and we always say no. So that skin in the game, we want what's best for our patients, and we wouldn't do anything. I think I can speak for most radiologists. We wouldn't do anything just for, I'm not exactly sure what that bias is. Is it monetary? It's one thing sitting and making these guidelines and thinking one in X amount of people. It's another thing actually dealing with people individually and seeing them as people, not numbers on a paper. It's different.
Yes, thanks very much, because I am concerned about the lack of data. And the fact that lack of data is impacting certain populations because we don't have the research that's needed. Going to Dr. Seeley, shocking that in Nunavut is the only territory that doesn't have breast screening. We know that, Nunavut, in terms of access to essential services, is lacking housing, often turning a blind eye to the folks of Nunavut.
Leah, you have exhausted all of your time
Oh, wow.
and then some.
I never look at the chair.
She avoids looking at me. I was a little bit generous, but you have exceeded, so we are needing to move on. So perhaps that question that she was alluding to, we can incorporate it further on in the discussions. At this point, I'd like to start our second round. Dominique, with the Conservatives, vous avez 5 minutes.
Merci beaucoup. Que d'intelligence.
Thank you very much. Such intelligence today. We often have this, but really today around the table we have men and women who are truly inspiring. Thank you for your presence and your testimony. I'll try to speak slowly so that you will understand me well. First of all, I'd like to say that I have had personal experience that I won't talk of here, but my colleagues are aware of it. But also, amongst my close friends, I have friends in their 30s who have had to have double mastectomies. And you're saying that more and more young women are grappling with breast cancer.